Dilated cardiomyopathy or congestive cardiomyopathy is characterized by ventricular dilation and grossly impaired systolic function, leading to dilated heart failure. The most common causes are ischemic heart disease or valvular heart disease. The basic problem is diminished myocardial contractility, which is reflected in diminished systolic performance of the heart. Abnormalities in myocardial energy metabolism are implicated. Dilated cardiomyopathy causes decreased ejection fraction, increased end diastolic and residual volumes, decreased ventricular stroke volume, and biventricular failure. About two-thirds of the cases of dilated cardiomyopathy are idiopathic. The remainder result from some underlying disease process. Secondary causes of dilated cardiomyopathy include ischemic heart disease, valvular heart disease, diabetes, renal failure, alcohol use, drug toxicity, nutritional deficiencies postpartum, post-infectious, and hyperthyroidism. Idiopathic dilated cardiomyopathy has a familial origin in 20 to 30% of cases, and genes coding for contractile proteins are implicated. In the majority of familial and sporadic idiopathic cases, cardiac-specific autoantibodies can be detected. Ischemic heart disease damages the ventricular myocardium both through necrosis and peri-infarct remodeling. Valvular heart disease causes cardiac chamber volume and pressure overload that can result in long-term myocardial dysfunction. Diabetes and uremia are associated with decreased myocardial contractility and dilated cardiomyopathy. Alcohol can be directly toxic to the myocardium, as can many drugs such as some chemotherapeutic inotropics and antidysrhythmic agents. Many nutritional deficiencies can cause cardiomyopathy, including niacin, vitamin D, and selenium. Peripartum cardiomyopathy usually develops in the first 3 to 4 months after completion of a pregnancy, after the period of maximum physiologic stress is thought to have ended. Dilated cardiomyopathies also may be the late consequence of previous viral, bacterial, or parasitic infection or an autoimmune process. Hyperthyroidism may present with atrial fibrillation as well as dilated cardiomyopathy, which may be reversible with treatment of the thyroid disorder. The most common symptoms of dilated cardiomyopathy are dyspnea and fatigue. Pulmonary congestion is expected, although fulminant pulmonary edema is uncommon. Palpitations and associated dysrhythmias may cause dizziness and syncope. Systemic and pulmonary emboli are common complications. Chest pain may be present but is usually nonspecific and unlike anginal pain. In the presence of dilated heart failure, blood pressure may be elevated initially. However, hypotension indicates progressive decreases in contractility. Extra harsh sounds and cardiac murmurs may be present as well. Dilated cardiomyopathy may be difficult to distinguish from acute myocarditis, valvular heart disease, CAD, and hypertensive heart disease.